Good morning, everybody. Welcome. Our late breaking news, today's impact of COVID-19 session is sponsored by longtime NATO partner, On Point Health Data. As leaders in the health data space, both NATO,
Hello.
now we have sound. All right.
Yes.
As leaders in the health data space, both NATO and OnPoint recognize the importance of preparing for the expected and potential impacts of the COVID-19 pandemic on the work that our organizations are doing on a daily basis. We are excited about the innovative and collaborative efforts related to the impacts of COVID-19 that each of the following presenters will be sharing with our community. We have just a couple of announcements for everyone today. The first one is a reminder that the exhibit hall is open. We have some good information for you there from our exhibitors, and we encourage you to stop by there. Pat Merriweather Arges from Project Patient Care and Shule Garovich from Mathematica will moderate today's session. Pat and Shule. Are you on mute?
Good morning, everyone, and it's wonderful to see all of you. And I apologize for I've had a little technical issue, but again, this is what we're all about. In terms of the event today, this is really a focus on NATO and also in terms of all of the initiatives. And again, I know that you're all familiar with this opportunity that we have to talk about how breaking issues. And so today we have with us a number of speakers, including just a plethora of events that we're going to be talking about, but it was very hard to reduce it just down to a couple. So what we did is we did go with a few events. And as you'll see here, we're going to be talking about some key areas, such as the use of information, primary care, nursing homes, opioids, disparities, and also talking about the impact of course on state data organizations. And with that, I'm going to note that our objectives are really to highlight the key areas, understand the value of information that's being utilized, and identify the value of actionable information that's leading to this information, and also suggesting that there are still some gaps in information. And with that, I'm going to turn it over to Shule to begin the meeting. Thank you.
Thank you, Pat, and thank you, Norm, and thank you for joining us for this hour. We know it's an important topic, and we wanted to cover, as Pat said, as many topics as possible. It is going to be a lightning round. We gave each presenter 8 minutes, so we'll have some Q&A at the end if we have time, but we also have a networking event at the end of today. So please join us there as well to have more one-on-one discussions on the topic. So with that, I'm going to start the conversation around data. And as I'm pulling my presentation to share, just give me a second. So COVID-19 changed a lot in our lives, the way we work, the way we live, and the way we interact. So we hope that some of those changes are temporary, but we also are expecting some of those changes are fundamental changes. And hopefully this crisis is going to create opportunities for us to rethink our healthcare system as well as the way that we utilize data. The data itself and the use of data for policymaking is something that didn't change with the pandemic and the evolving situation. The way that we utilize that data and the pressure to get timely and quality data have increased, and in some cases it became really life and death issues such as nursing homes. So what with the collaboration with NATO, our researchers at Mathematica start tracking the publicly available COVID-19 data. And in this graph, what you are seeing is the sources in the yellow bars and the outputs that are on the green bars. As you see, there is a proliferation of COVID-19 data focusing on key aspects such as counts, deaths, infection rates, new cases, and as the testing evolved, testing numbers and positivity cases. But the sources of data are taking us back to the main sources that we had in our system. And as you see, CDC providing the majority of the sources, followed by state health departments. You do see that the media became a source of information as they also collected their own information through surveys and interviews with the state officials. The data, the nature of the data is evolving as the pandemic evolves. We have surveys as well as the policy guidelines where there is some analysis and initial reviews of the telehealth and other data points that you're going to see throughout this presentations as well. The focus was on public release of this data. A lot of states established their dashboards. Local communities created their own to address their own needs. And initially, the focus was on healthcare services and capacity as well as the pandemic was evolving. We are looking at using the existing data sources. We haven't seen a lot of new data streams developing, but that's also additional step that the states are working on at the moment. The challenges are similar to what we all know in our field, and people who are attending this conference are passionate about data and high quality data. What we are seeing across the states is a variation, as you expect, in the detail that is provided in the public reporting. We do see variation in geographic aggregations. Some states are moving to a zip code level data. Some states are still staying at the state level or county level. The definition of concepts across the states are also different. What they call as positive results or testing, what is included in the testing, seem to vary across states, and that's something that we can collectively work on to improve. Finally, additional information around workforce and socioeconomic factors or adjustments in the rates are something that is also evolving. And as the states are updating their data streams, we see a push for collecting more race and ethnicity data, as well as some sociodemographic characteristics of the cases. The frequency and the quality is another challenge in the data reporting. And then there were some recent newspaper articles coming out about the issues that certain states observed in the delays in testing that impacted the public reporting and case counts. It seemed that the whole system from testing to reporting has impact on the quality, and the states could do a better job in providing more context into the limitations of their data. As you can imagine, at the beginning, the states were after a signal for the COVID trends. As the time passed and our established data streams went into effect, and now we are spending more time looking at what the noise is around these data sets and improving the analytics around impact and estimates for the future. And finally, as states are pressured to collect more data and publish that on public websites and do analyses, as you expect, they are under tremendous pressure from their revenue cycles because of changes in revenues such as taxes on petroleum and transportation. And unemployment, the revenues are declining, although their expenditures are increasing due to the pandemic. We've seen states taking actions in terms of budget cuts. some states passed temporary budgets. And then what we are seeing is that there are also a few states that are working on Medicaid waivers and reducing, unfortunately, provider rates to balance their Medicaid budget and therefore state budget. At the same time, as we are moving towards thinking about from immediate response to recovery and resilience policies, states would need additional resources to create their policy to manage the pandemic, which is also going to be creating pressures for the budgets. So with that, I'm going to turn to Bianca to take the next, which is going to be the workforce. All right, Bianca.
Shule, thank you for setting me up well. I am just trying to bring up my slides here, so it might just take a moment. So just briefly, I'm Bianca Frogner. I'm the director of the Center for Health Workforce Studies here in Seattle, Washington at University of Washington. I'll be discussing 4 key challenges that we have been seeing around the health workforce data collection throughout this pandemic. There are many data challenges, and I could go into each one of these in much greater detail, but hopefully this gives you a sense of the broad sense of challenges that the field is facing. So hold on just a moment. It should be coming up any moment now.
It came up, Bianca.
Okay, so great, perfect. So I'm going to kick off by talking about a topic that I think many people are familiar with whenever thinking about the health workforce, which is about shortages. So suffice it to say, before COVID, many folks read about issues around shortage of primary care workers, sometimes even nurses, shortages in rural areas versus underserved communities. And during COVID, this became even greater of an issue as hospitals in particular tried to figure out how to surge their workforce in order to handle the increasing caseload of COVID patients. And the key occupations that really came to the forefront during this time period were not just the physicians, but also the registered nurses, especially those who work in the ICU units, also respiratory therapists. That became a topic that an occupation that really hit people's radars as it became critical to identify where we had enough respiratory therapists to work on the COVID units, as well as nephrologists to help COVID patients through their challenges and the symptoms that they developed. So the issue that we really struggle with is that data for these different occupations are held by different professional organizations if they are licensed. And there are a number of healthcare workers who are not licensed. So there's no central repository of data to help us identify how many healthcare workers do we have, where are they located, where are they working. And this has been a long challenge and continued to be a challenge throughout this pandemic. This is something that our field has been working on to identify if there are ways we can create minimum data sets so that we have some basic information on all healthcare workers. Within our state of Washington, there was a discussion about creating some sort of a centralized system or data set, which was like had all healthcare providers listed with this minimum information. So again, every state had to think through how to come up with this data, but had to deal with whatever data that they had. So ongoing issue. The next issue I want to talk about is employment of healthcare workers. And I don't think it's quite coming up here. So even though we have a shortage of workers, simultaneously during the COVID crisis, a number of healthcare workers were also laid off and they were unemployed. And a lot of this had to do with the fact that clinics had to close, elective surgeries stopped during the height of the COVID pandemic. But even as clinics are reopening, healthcare workers are still finding themselves unemployed. And as patients rethink what kind of care they are willing to go and seek at this time during this kind of post-peak pandemic period, it's unclear what the future is of employment of many different kinds of healthcare workers, particularly, I would say, in the dental field and to some degree in the primary care field, despite great advances in the use of telehealth. And the issue that we've come across is just identifying who is actually getting furloughed and from where. This data would come from potentially an unemployment office within a state. So here in Washington State, it would be called the Employment Security Department. where they are the ones who process unemployment. But it would take somebody some time, and we've been lucky to have this in the state, that somebody has actually taken the time to break down the occupation from which each of these workers who are unemployed are have last held, and then and once you have that information, ideally, if we had it, we would be able to go hand pick those people and get them redeployed where we know that there are consistent shortages. So again, this takes quite a bit of coordinated effort at a time when especially unemployment offices are incredibly packed with other things that they have to worry about. Healthcare is just one of many industries that obviously have been hit, but it's an area that many of us in the health workforce arena have wanted to identify where these unemployed workers are and how we can get our hands on them and redeploy them. The third issue that we've been encountering in the health workforce arena are issues around COVID risk of the healthcare workers themselves. So Shule mentioned this also. So the news has become a source of information for how many healthcare workers are actually sick and possibly dying from COVID. CDC does collect some of this information, but unfortunately, the numbers are a little bit all over the place. So just recently, a couple colleagues and I have talked about the differences in numbers. And CDC, at least a couple weeks ago, was reporting about 600 healthcare worker deaths, while if you process data coming from the Centers for Medicare and Medicaid Services, you had about 700 healthcare workers who have died from COVID across the country. And then if you look at what Kaiser Health News and The Guardian have put out by combing obituaries, they have come up with about 900 healthcare workers who have died of COVID. So in general, you can see that the numbers are, the range is quite broad, and we're just scratching the surface of understanding of how many healthcare workers are at risk and are dying from COVID. And we need to do a better job identifying these workers. And part of the issues here is that we need to know this information in order to better plan for the supply of workers that we need to deploy across the healthcare spectrum. So hospitals have definitely been a key area of concern early in the pandemic, but now nursing homes also are struggling to keep their workforce in place given the high risk of COVID within that setting. And in order to figure out how much PPE and testing we need to distribute across all these settings, we need to also know, where are the risks the highest and to get that equipment that we need to those locations. So the last issue I'll just bring up here is about the resiliency of the health workforce. So as we think about the long-term trajectory of COVID and where we're going, it's clear that COVID isn't going away right away. We're still going to be with it for a while. And this is a little bit fuzzier of an area, but it's not clear how well our healthcare workers are doing. I think generally the feeling is many of them are not okay, especially in the COVID hotspots. So how do we track that information of who's not doing well and what kind of needs they have, and trying to identify the resources and solutions that we can get into those individuals' hands so that they don't have to suffer unnecessarily. So that area, I would say, needs probably the most amount of work to actually identify good data sources to do this kind of tracking. I would say individual health systems or healthcare organizations may be tracking their own health workforce burnout rates and satisfaction rates, but we need to do more, I think, at the national level. So with that, I'll stop there and I'll be handing it off to Dr. Diane Rittenhouse.
Thank you so much. Let me load my slides. Okay, my name is Diane Rittenhouse, and I'm a family physician and health policy researcher at Mathematica and UCSF, and I've been asked to talk about COVID-19 impacts on primary care. See if my slides will come up. My contact information here and my Twitter handle. There we go. Okay. So what is primary care? Typically, we think of it as family medicine, general internal medicine, and general pediatrics. It's the first place that people go for preventive health care, urgent health concerns, and management of chronic illness. And it's the place people return to again and again over the course of a lifetime. So primary care is at its heart relationship-centered care. And there's plenty of evidence that excellent primary care constitutes a strong foundation of a health system that is high quality, low cost, and equitable. So let's talk for a minute about primary care pre-pandemic. Over the past decade or so, primary care practices have been undergoing a transformation. They've been asked to adopt and use new electronic health records and make them talk with hospitals and pharmacies and patients. They've added new team members to the practice, like care managers and clinical pharmacists. They've been asked to try out new payment mechanisms, and every insurance company is trying something new and different. They've been asked to measure and report a variety of quality metrics. They've been asked to get certified as patient-centered medical homes. And the crisis really stems from the fact that through all of this transition, primary care practices have been chronically under-resourced. So in the United States, about 5 to 8% of total healthcare spending goes to primary care. 5 to 8%. So that's very low compared to other high-income countries. And from a basic payment perspective, the fee-for-service mechanism that pays doctors when they meet a patient in their office face-to-face and they do something to that patient, a procedure or a test, doesn't really work for primary care because it doesn't value and pay for the time that primary care providers spend talking and listening and educating patients and coordinating their care across the healthcare system. But primary care is not just under-resourced from a financial standpoint, it's also lacking in human resources. So Bianca mentioned the primary care shortage. In part, there's all this transformation requires technical assistance that small primary care practices don't necessarily have, but also primary care physicians are aging and nearing retirement. Emotional exhaustion and burnout are high. Not enough US medical students who are typically burdened by high educational debt are choosing primary care because these are the lowest paid medical specialties. So then the pandemic hit. The first thing that happened was everyone stopped going to see their primary care doctor in person. Why did this happen? Partly because shelter-in-place orders went into effect, partly because all medical resources were going into emergency rooms and hospitals and ICUs, and people were afraid, and rightly so, because primary care practices did not have access to personal protective equipment and adequate testing to protect their staff and their patients. So here's what that looked like from a data standpoint. These are data from a study conducted by colleagues at Harvard that show that ambulatory care visits fell by 50 to 80% over a single week in March and continued to be depressed for weeks. What then happened was revenue evaporated, and there was an immediate economic impact on practices. Layoffs, furloughs, bankruptcy, unemployment became common, especially among physicians in small private practices, many of whom serve rural and underserved areas of the country. There was also an immediate health impact. Not only were providers getting sick and needing to quarantine, but their patients stopped getting care. This is just a single example, but you can see that childhood immunizations dropped dramatically when people stopped seeing their primary care doctors. So you can see this dropped off at March 13th when the US national emergency was declared. Primary care practices immediately responded to the lack of in-person visits by picking up the phone and learning how to Zoom. You can see the impressive rise in percent of visits that were telehealth visits here. Some health systems reported a 4,000% increase in telehealth visits almost overnight. But in many primary care practices, this work was done for free. One by one, insurers began paying for video and phone visits, but this took a couple of months to happen. And in many cases, these payments have not reached parity with in-person visits. But these numbers and graphs obviously don't tell the whole story. The Larry Green Center launched a weekly survey of primary care providers and asked open-ended questions, and the answers from just a couple weeks ago reveal the trauma resulting from the stress of the pandemic. Continuously changing regulations, billing requirements, COVID-19 protocols, shifting staffing levels, and an unpredictable revenue environment. These feelings of helplessness isolation, and loss of power and control have really impacted the workforce. And we're seeing increased levels of anxiety and depression among frontline providers. Here you can see the comments about this new normal feeling crushing and demoralizing, issues of morale, people complaining of compassion fatigue, providers with high stress levels and emotional exhaustion, and even suicide. In the midst of all this economic upheaval and trauma, there is a need to focus on the survival of primary care, especially on the large number of small, independent primary care practices that are not tied to large health systems or hospitals with reserves to help keep them afloat. Keeping the doors open, the PPE coming, the workforce and the patients safe and well, paying for telehealth for the next few months. But also, as we look forward to the future, there are some changes that need to occur if we want primary care to continue to serve as a high quality foundation for our healthcare system. First, we need to invest more in primary care. The Millbank Fund and the Primary Care Collaborative have provided leadership in this area. Prior to the pandemic, states like Oregon, Colorado, Vermont, Maine, Delaware, to name just a few, were pioneering the way with state legislation. They're working on defining exactly what counts as primary care and determining the percent primary care spend with an eye toward increasing the total primary care investment in their states. Second, we need to shift away from the fee-for-service payment for primary care toward capitated payments. Those physicians who are paid by capitation have more flexibility when and where and how to see their patients. And that means surviving and delivering care in all sorts of ways during the pandemic and beyond. Third, primary care practices need to continue to transform and improve. One tool that is the hot topic of today is telehealth. Patients and providers have experienced it and no one wants to go back. But practices need help with this and other transitions. And that help needs to come in the form of both money and technical assistance. Which brings me to the last thing I want to say, and I think it's really important, and that is that primary care practices need both financial support and human support to continue to serve and to continue to transform. Thank you. Now I'm happy to pass on to Nelly Vasquez-Roland.
Are you on mute, Nelly?
Okay. I apologize. I just logged in. I am going to try to upload the PowerPoint. By any chance, would it be possible to skip me and allow someone else to give me some time to get this uploaded? Thank you. I'm so sorry.
Pat, would you like to go first on the nursing homes?
There we go.
Greetings, everyone, and it's nice to be back with all of you again, talking about a subject I know that's very important to me. And I'm Pat Merriweather-Argus, Executive Director at Project Patient Care. And prior to joining Project Patient Care, I worked for 26 years with the Illinois Hospital Association. So I'm very familiar with all the data issues, and I served on the NUBC, and again, quite familiar with the data issues. And then I moved over to head up the Quality Improvement Organization for Medicare for about 5 years, covering 3 states. And that's where I really got an introduction to the continuum of care and the challenges that it brings. And so that's why I'm focused on the patients and residents, because I think that is where we're going to have a number of opportunities as well. Now, as I move to the next slide, I just want to say that the nursing home issues were the perfect storm. And sadly, it really occurred with Kirkland. Kirkland was the major outbreak, with so many nursing home residents dying in just a short period of time. But again, I think that we ignored or didn't pay attention or didn't connect the dots with Kirkland. because what has happened is over and over again, state by state, we've had Kirklands and we've had a lot of deaths with the residents. Now, to give you a perspective, it's a little bit different than hospitals. There's over 15,000 nursing homes in the United States. And with that, it means that there are a lot of opportunities for spread. And the recent research also demonstrates that if you have the coronavirus, the COVID-19, high rates, positivity rates in your community, that it spreads to the nursing homes. And one of the lessons learned from the nursing home in Kirkland was that the COVID-19 was brought in through nursing home staff. And as we know, COVID-19 is oftentimes asymptomatic in people, or in some people, it's pre-symptomatic. And so it's very hard for anyone sometimes to know that they have COVID-19 unless they have apparent symptoms. So as a result, the spread has occurred from the outside, not from the inside. And on March 13th, all nursing homes in the United States went on what we call lockdown. That means that no family visitors, no friends, no volunteers, no service people could enter the organization. It also meant no beauticians, no dentists. Again, it really was it's the lockdown that excludes anyone from coming in. And that's to control the spread of COVID-19. But again, our signal at Kirkland was it was brought in by staff, and yet the nursing homes oftentimes were the last ones to get testing kits. So think about this. It's the perfect storm because nursing home residents eat in congregate settings so that they have their meals together, they have their activities. They oftentimes are sharing a room with another person. So again, the opportunity for spread is very fast. And think about it. Nursing home residents are the vulnerable population that has been talked about almost since day one with conditions, health conditions that need support and are very vulnerable to infections. There also was the continuous lack of training or support on infection prevention. And what I mean by that is it's been about 4 or 5 years ago that CMS, the Centers for Medicare and Medicaid Services, actually released a report on the infection prevention, and CMS has an assessment tool that was in place about 4 or 5 years ago, but it was never enforced. And so as a result, nobody really knew the conditions of nursing homes in terms of being able to prevent or control infections. The lack of personal protective equipment has been tremendous in nursing homes. They were at the end of the end of the line when it came to PPE being distributed. And I actually sit on our state HAI committee, as well as I was on an ad hoc committee on nursing home care. And I can tell you, we heard from many nursing homes that they were getting garbage bags because that's what they were using for gowns. And they never had enough equipment because, again, they were never set up to be that level of intensity within a nursing home. And yet they were at the end of the line. Again, even that was brought up in Kirkland. So again, I think you have a number of issues there that were apparent at Kirkland, but never got addressed going forward. The lack of the testing kits, I think we know nationwide that's been an issue, but it really was extremely apparent within nursing homes. So right now, there were about over 15,000 nursing homes, and about a week and a half ago, 1,000 of them were getting testing kits, and they're going to roll it out. So I figure by November, all of the nursing homes will have the testing kits. But think about in a nursing home, it's 24/7, the staffing. So if you're testing staff, and you're going to do it twice a week, it's quite a few kits that you're going to be running through. And then if there's any patients or residents that show symptoms, that also is going to take up a number of kits. So again, the volume is intense in terms of the need for testing kits as well as personal protective equipment. And then the staffing shortages. We know that nursing homes oftentimes have been, many times I should say, have been short-staffed. And that's because the turnover rates are high. The work is very intense, sometimes very stressful, and yet the reimbursement is very low for nursing home staff. So having a staffing shortage in the middle of a pandemic is not what anyone wants. But the reality is many of them are short-staffed right now. And especially that's challenging because, as I said, residents are taking their meals in their room. They aren't going to congregate settings. So that means that the staff that are there are doing much more work than they did before. And the stress levels are still very high, almost what was being talked about in terms of the workforce. Now, in terms of the lockdown, it also provided an opportunity for residents not to have conversations or communications with loved ones, as well as some of the advocates, whether it's the ombudsman or the local people that take care of some of the residents. There's no opportunity for them to be able to visit the nursing homes and to go in the nursing homes. There has been some relaxation in some states. I'm in one of those states. I'm in Illinois, but I can tell you that the relaxation has not been that great because you have to go 30 days without a COVID-19 case, a confirmed case, and that's very hard for many nursing homes to do, especially when it's out in the community. Now, this is a slide, and again, the data is based upon the CMS data. CMS is collecting a wealth of information and data, and this just demonstrates the ones in the dark orange are the ones that have higher rates, higher percents of deaths linked to nursing homes. So I'm in Illinois, and I know our numbers have gone up since this was done on August 13th. And just to give you a perspective, I'll talk about this later, 43% of all of the deaths, COVID-19 deaths, are nursing home residents. But there's some more staggering figures with that as well. So think about the challenges that they're facing right now. In terms of the data that CMS is collecting, and again, it's been public. I just looked this morning. I think the data from August 2nd that was reported is available. It's available by every nursing home. It's a spreadsheet. You can download it. You can manipulate it. Again, it's great information. They have weekly reporting. There's fines for non-reporting. And you heard just yesterday that they were giving out fines, about $15 million in fines, some of it for not completing the assessment tool, the infection assessment tool, as well as not reporting to this data system. It also demonstrates the sufficient levels for PPE, the personal protective equipment, and that includes of course, the gloves, the gowns, the masks. It's again, everything that you can think of that is needed to protect staff within nursing home, to make sure that, again, they're also being protected. But the patients, the residents have to be protected. So think about that. If you're in a room, if you're sharing a room with another person, you've got to have your mask on at all times within that room. And again, oftentimes there's a drape between them, but making sure that not only the staff, but also the residents have that as well, the protective equipment. There's information on the testing results. It tells you how many were done, how many tests were done, how many were confirmed, and they break it out, which is great. It's broken out by residents and staff. So again, you have a wonderful opportunity there. And then in terms of deaths, that's done weekly as well as totals. And like I said, the positive COVID-19. Now, the reason this is important is I want you to remember these three numbers, and they're going to change over time. I wish they'd go down, but they seem to be going up. 43% of all COVID-19 deaths in the US were nursing home residents. But how that translates, it seems like, okay, 43% of, but the numbers are huge. And for the entire nursing home population, 1 out of 20 has died from COVID-19. And in terms of the number of days they've been on lockdown, it's 159 days. Now, how many of us could stay in a room for 159 days? And so, there's associated conditions with that, not only the loneliness, but also the functional status and the mobility ability as well. So again, think of these numbers, think of the impact that it's having. It is a hot issue, and it's still a long way from being resolved. There's many factors that go into this, and you just can't address one factor. It's multifactorial. So again, what we need is the continuation of this data. It's wonderful, and it really is being utilized to do targeted initiatives. And with that, I'm going to now turn it over to Nellie, who's going to talk about another issue that we need to keep our eyes on, is the opioid issue. Nellie?
Hello, everyone. Thank you, Pat. That was a great presentation, and I'm just a testimony that who's in that same exact situation, and he is deteriorating fast, and we're counting hospice right now for him because of the deterioration. So very personal to me, so thank you. I am going to try to share a presentation here. Let me see if I can do this. Share, no, I don't want to do that. Hold on. Share file. I'm trying to do a PowerPoint, so if anybody can help me here, that'd be great.
So you may need to tell it to show all files.
Show all files. Okay. Brian, can you show me? Let me grab my partner here who can help me. It's on the, here's the presentation. So how do I pull it?
Can they see it?
They can't see that.
No, wait, you need to load the file from the hard drive. So you need to actually find the file on the hard drive.
Okay,
I
so
can't see that.
here is the file. Hold on.
And then click OK once you found it.
Okay, I have it right in front of me, but I'm trying to figure out how to share it. Hold on. Can't see it, right?
No. Can you send it to me by email real quick, and then I can load it from my end, and then you can go ahead and start talking, and we'll catch the slides up with you.
Sure.
Or we can go into Marcus while we're getting that straightened out. Either way.
Yes, please. I'll send it to you. So please go to Marcus. I apologize, you guys.
Okay, not a problem. Okay, let's go ahead and we'll go to Marcus. I'll let me load up Marcus's slides for him.
Good afternoon, everyone. Thank you so very much for this opportunity to present to this August group. Marcus Robinson of Social Innovation Group of Chicago. Over the last 20 years, I've served on the board of directors of Spectrum, Lakeland Health, and in Michigan, and the Unity Health System in New York, and currently on the Patient Safety Committee at St. Bernard Hospital here in my neighborhood of Englewood, Chicago, which is the poorest neighborhood in Chicago. and also receiving, some of the toughest, most harsh experiences with the pandemics. I wanted to talk about kind of the multiple level of pandemics here, that multiple level of epidemics that are going on, I believe that are going on with regard to COVID and its universal impact on the system that you've heard lots about, but also the opioid and drug addiction epidemic that has the grip of this nation. And then, of course, gun violence, which I see as a kind of a triple epidemic. I'm looking for the advanced slide mechanism for this particular presentation. I don't quite see it, but here you go. So there is here, I want to put a face on this. And here you have, Monica Masco and her daughter, and they lost their mother and great grandmother respectively. Ethel Huntley to COVID-19 in a nursing home, but in a nursing home in an environment in a zip code where we now know that there's lower levels of income. We call that poverty nowadays, and higher levels of incidence of a variety of disease factors that are related to the so-called social determinants. And as we move on, I just want to make it clear that it is not only the zip code today that has an impact on the social determinants and the outcomes that people experience, but also it's historic. It's been going on for a while. In this neighborhood of Loudon County here, back in the day, it was known as Bloody Loudon. Because of the lynchings and white supremacy and KKK activity and all that kind of stuff. And that kind of culture lives into the day. And even during those times in the 60s, civil rights marchers like Martin Luther King and John Lewis crossed this county on their way to Montgomery and Selma. And I bring that up because 55 years later, with the mission of the civil rights movement to really tackle economic inequality, so-called Poor People's Campaign, still today, 30% of the residents there live in poverty, making it one of the most poorest counties in the state. Unlike my neighborhood, they've got no hospital. And in that county, folks like Sandy Oliver and Pamela Rush have to seek treatment many miles away from home because, many folks just are unable to afford health insurance. So we keep moving on to the next slide. The pandemic has an impact across all of the places where there's high levels of poverty and where we know that there are higher incidences of disease factors like, diabetes and obesity and heart disease and the related. And in 2020, because of this pressure of being what I believe is to be the stay-at-home orders and all the things that we've talked about that are impacting physicians and practices and congregated care facilities, it's also happening on the streets. In 2020, here in Cook County, opioid overdoses are doubling last year's numbers. That's a big deal. And the coronavirus and gun violence and opiate addiction are disproportionately affecting Black people, according to Dr. Panoni Arun Kumar of the medical examiner here in my county. Our county executive, sounded the alarms, saying that these are three overlapping pandemics, and what we face is a result of centuries, if not decades, of racial inequality. People are literally dying around us because of our inability to get at these preventable causes in a systematic, science-based way that allows us to resolve the underlying conditions that drive these social determinants. Next slide, please. The third one is this gun violence thing. Communities of color have endured not only the weight of COVID-19, they've also had to endure the recession and the social unrest. And all of this kind of bears down on gun violence. This photograph I have here is of an artist exhibit of 110 different pairs of shoes, just identifying the folks who've been shot in a particular region in the boroughs of New York City. It's just this amazing rendition of how this is impacting people's lives. We're literally, if we were to walk in the shoes of people who live in those disinvested, low resource, high risk communities, you and I would likely know someone, be kin to someone, or actually be someone for whom those shoes represented. And so it's a really big deal. It's affecting everyone. Please move to the next slide. So ultimately, the data, while incomplete, does reveal a picture that suggests that Latino and Black Americans are 3 times more likely to become infected and twice as likely to die from the COVID-19 disease than from March through May, as compared with their white American counterparts. Native American groups are disproportionately affected as well. The Navajo Nation, as you've seen recently in some of the media, has some of the highest levels of coronavirus infections, all for reasons that are completely explainable and understood at the level of the social determinants, but somehow or another, as a larger community, as an ecosystem of providers, not just medical providers, but public health folk and housing folk and folk in a variety of different levels of nonprofit activity, we are all finding ourselves overwhelmed by the impact of this virus as it layers on top of numerous forms of racism, aspiring to make Black and Latino and Indigenous people more vulnerable to this disease and its symptoms. And then finally, there are a few points I'd like you to remember more than anything else, and that is that pre-existence conditions definitely play a huge role, and wherever we find folks that are living at the margins, you will find higher levels of impact here, because most of these folk can't do jobs or don't do jobs that allow them to socially distance and work from home in many cases. Pre-existing conditions can also be a result of systemic and structural racism. This quote here from Gino Tai says that I cannot overemphasize enough that social justice and systemic racisms are the root problem in the disparity scenario. The face value on that is pretty high. The data is still mixed. But I believe there's enough here to go on to say that, to really see that people of color are hit harder by COVID-19, no matter where they live, which is to say that folks who are living in tight city quarters or in the suburbs or now in the rural areas are all finding themselves at risk and experiencing the risk of COVID-19. Native American reservations are challenged. The racial demographic in the data for COVID-19 is incomplete. The racial demographic data for COVID-19 is incomplete. We just have to do a better job at collecting that information. I would support any effort by CMS or anybody else to collect that information more granularly. Finally, the medical community just needs to build more trust with people of color. The building of trust with people of color in the medical community is akin to the need of the building of trust that's required between the police community and people of color. Just not as intense, but it's along that same continuum. So we've got a lot of work to do, coming face to face, heart to heart, person to persons with the people we serve. And on that note, I'll close my presentation and turn it over to my colleague, Nelly Vasquez-Rowland.
Thank you, Marcus. Okay, so we finally got it working, and I wanted to present today really a case study of how a safe haven responded to both and is responding to both the COVID-19 and the opioid epidemic. Just to take us back to the month of March, actually beginning of the year, we have a homeless program that actually serves over 5,000 people a year. We are set up as an organization that actually provides semi-private accommodations. So a safe haven was not your typical congregate living shelter with cots laid side by side, but people actually had semi-private rooms. We also have very strict infection control policies. So while many of the people that were, obviously responding to the COVID-19 in the homeless scenario were forced to decompress, fortunately, a safe haven did not have to respond that way, and we kept our beds full and intact. Due to our infection control policies that we've had in place, mostly because of, traditional healthcare concerns such as flu, it was flu season, and the fact that we're always concerned about hepatitis and tuberculosis and things like that, we actually started the process of preparing specifically for COVID-19 on January 31st, which documents our very first email going to our executive staff to start looking at our policies to really consider, what would it look like in terms of what we would have to do to respond to a pandemic. And the reason why we were alarmed was because in Chicago, a safe haven's located in an area called North Lawndale. And much like Marcus described his community, we are also at the epicenter of poverty, homelessness, addiction, and all the things that you can imagine that many communities of, poverty face. And we happen to also be located a few miles from the Chinatown, which happens to have a very large homeless encampment. So it was very likely for us to see someone from the homeless encampment coming from Chinatown and entering our program. So that is the reason we were extremely tuned in to what was happening in Chinatown. And actually that happened to be the day that the US closed the borders. So on January 31st, we started the process. We also knew that the homeless population was particularly vulnerable based on the underlying conditions that they faced, which included high unemployment, obviously, SUDS, substance abuse disorders, physical, mental health issues, very likely to get very, very sick, very likely to spread it, and very likely to die from it. So on March 11th, we actually held a meeting with Rush University Healthcare System, where the conversation evolved around the fact that we had 25 homeless on that day in the state of Illinois. And we considered the fact that their projections on that day were that within 2 weeks, we would probably see about a 6,000 number of people being affected. So because of that, we came together and decided that we needed to figure out a response that was going to be very unique for the homeless. And in fact, that conversation in terms of the planning process started again on March 11th to build a 100-bed facility. A safe haven happened to have 7,000 square feet that we were converting into an outpatient center that happened to be in our 140,000 square foot facility, which also houses 400 homeless. That conversation led to us building a model that provided healthcare, medical team from the Rush University healthcare team, and also providing a behavioral healthcare team to help assist with the mental and behavioral healthcare issues that the vast majority of the people that we would be serving, which would be the homeless and the doubled up populations. We needed a way to fund it. We reached out to CDPA with the very first medical respite isolation space that was completely dedicated to serve the homeless and doubled up populations. As we know, the African American community, the Latino community has a very high incidence of having doubled up populations, which attributes the reason as to why we've seen such an outbreak within our communities. On April 11th, exactly 30 days from our meeting, with Rush, we were able to open up that medical center, and we attended a conference, or a presentation with the mayor's office. What we did at A Safe Haven is we provided same-sex pods with dividers to provide semi-private accommodations. We also provide 3 healthy meals a day through our catering services that we also have on site. We provide medication management with our comfort care workers. We also have very deep cleaning sanitation services provided by our sanitation workers. Again, our behavioral health care team has provided in-person and tele-behavioral healthcare services, and we also are offering individualized case management and discharge services for the people that are entering our program and discharging to a much more appropriate level of aftercare. The vast majority of the people that we are serving are actually entering our system. If you look at the continuum of care on the left-hand side, you will see that we have the medical respite, which leads to transitional housing, additional healthcare services, behavioral healthcare services, job training, education, and access to jobs and permanent housing. Many of the jobs are offered through our own social enterprises, which include a landscaping company, include a catering business. We do job training for those businesses. And we also have a staffing service, which happened to have placed over 1,018 people into jobs last year that were formerly homeless. So it was a big coup. It was actually a number that was greater than the year before. So although we stopped outside intakes in March, we still were able to exceed our last year's numbers, which was a very big surprise to myself.
2 minutes.
Okay, the Rush medical team provides the in-person practitioners, physicians, and medical PPE supplies. And as was mentioned previously, Chicago in particular is experiencing almost a double in terms of the increase of the overdose deaths, mostly due to fentanyl. Next slide. Okay, so what we've done in effect is we've created a very innovative behavioral healthcare integration delivery system. So what has worked for the COVID-19 response has very positive implications for what we can be doing for the opiate population that is typically cycles in and out of emergency rooms and cycles in and out of the criminal justice system. So by having a way to have an integration between institutional health with behavioral health in a community-based setting, we're not only able to address the individual medical stabilization piece, the mental stabilization piece, but we're also able to discharge them to a much more appropriate level of care that is also addressing all the other coexisting social determinants of health. So we're very excited about the fact that we've had over 200 people that have come through this COVID-19 medical respite space. We have a 95% satisfaction rate according to our exit surveys, and we have had a 100% success rate with only one person being sent to the emergency room, but 100% survival rate. So we do have a little YouTube here if anybody wants to take a look at some of the testimonials. And next slide for all of the contact information for anybody that's interested in learning more about the work that we're doing right here on the front lines at A Safe Haven. And we have been doing for the last 25 years. This is an exciting moment where we can potentially use this crisis to really integrate institutional health with community-based behavioral healthcare settings. And I look forward to continue to collect this data to show the proof of concept. So thank you.
Thank you so much to all speakers. Really, you did a tremendous job to cover your topics in 8 minutes. And what I'm reflecting on is that as the virus is attacking our vulnerabilities inside our body, it's also attacking our social vulnerabilities as well as in the healthcare system. We have 5 minutes left. So I am hoping to maybe ask quick questions that we received from the Q&A. Norm, does that okay with you?
Yeah, let me ask one real quick. There's a question here for the group that says, because these data are not included in commercial claims data, does anybody have a recommended workaround? And I'm still not sure that Pat can hear it, so let me just pump it out there so Pat can see the question. I think it may be for Pat.
So while Pat is reading it, let me just ask to Dr. Robinson about the collection of race and ethnicity data. The question
Yes.
is about, since this data is coming from mainly hospitals, what do you recommend how hospitals should approach collecting race and ethnicity data, especially if the person is identifying with more than one race? Marcus, you are on mute, I believe.
Yeah, I thank you for the question. It's a great question. Start with your basic demographic data. How do that people self-identify? Whether they're Black, not Hispanic, or Black and Hispanic, or whatever. The normal kind of things that we do with that kind of work. And if people have more than one ethnicity they want to identify with, allow them to do so. Either by selecting it on an online form or writing it in other. If that opportunity exists there. It's just one or two more questions to ask that will help us get more information. It'll help us serve ourselves that much better. Thank you for the question.
Thanks, Marcus.
Shirley, I think we're going to have to make that be our last question. We have another session starting in 2 minutes. And
Hi, this is Pat, and I don't know if it was regarding any nursing home issue. I can see you, I can't hear you though. And I'm looking at the question. In terms of any commercial information on the claims data, the data that's being submitted to CMS on the nursing homes, and that's where I can talk about the nursing homes, is it's every resident. One of the things that people forget is on a lot of the quality measurements that CMS, the Centers for Medicare Medicaid Services, collects, is it includes everyone. And I do have to say that if you exclude a population or you exclude anyone, it does have ramifications for you. But I just want to say, and I'll turn it over to Slay in a minute. I think this has been a wonderful session. Again, so many, and I've heard it before, so I know what I'm talking about through our dry run. These are hot issues that, again, if we close our eyes, and we are closing our eyes, you saw that cliff for immunizations that have dropped off, the repercussions for later on, the issues going on with opioids, and the data is right there now in terms of workforce as well as our disparities. They're very apparent. We can't close our eyes, turn it off anymore. We've got to deal with it. And certainly, again, for me, the nursing home issues are tremendous as well. So I'm going to turn it over now to Shalay to close us out. Thank you.
All right. Thank you, Pat. Sorry for the technical issues here. So we are going to conclude our session. Please remember to fill out the evaluation forms and let us know how we did so we can do better next time. But again, appreciate all the time and effort the presenters put together. And I can't express my gratitude to all of them for their excellent, excellent presentations. Thank you so much.
Thank you.